Hello and welcome. My name is Dr. Jack West, and I'm a medical oncologist and the founder and CEO of GRACE, the global resource for advancing cancer education. This is part of a series of podcasts covering challenging clinical cases in lung cancer that don't have a clear, correct answer for the best treatment based on the evidence, and they therefore require our best judgment as experts consider the options and the merits of one treatment over another. The same series of cases was discussed with multiple experts in the field of lung cancer from several different institutions to provide a better sense of where there is consensus and where there is still a wide range of treatment styles that might all be considered appropriate. Each podcast starts with a brief thumbnail of a case presentation and then discussion from a live program done with Dr. Robert Doble, Assistant Professor of Medical Oncology at the University of Colorado Medical Center in Denver, Colorado, and Dr. Jyoti Patel, Associate Professor of Medical Oncology at the Feinberg School of Medicine at Northwestern University in Chicago, Illinois. The discussions will then continue with commentary by several other clinical experts, including Dr. Suresh Ramalingam from the Winship Cancer Center, Emory University in Atlanta, Georgia, Dr. Jonathan Goldman from Premier Oncology in Santa Monica, California, Dr. Julie Bramer from Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland, Dr. Heather Wakely from Stanford University Cancer Center in Palo Alto, California, and Dr. Karen Reckamp from the City of Hope Cancer Center in Duarte, California.
So let's move on to advanced disease. This particular patient is a 73-year-old Asian never-smoking man with a lung adenocarcinoma and multiple liver metastases at the time of his presentation. His initial biopsy also has tissue sent for molecular testing that shows an activating EGFR mutation. And he has a great initial response to Tarceva, as we do often see in patients with an EGFR mutation. That's his first-line therapy. But around 14 months after he starts that, he shows on his scan some modest but convincing progression. It's still less than he started with, but it's clear that there is progression happening now. And so my initial question is, when are you inclined to make a change versus are you inclined to sometimes watch people as they're progressing in this situation? And then once you do decide to make a change, what are you inclined to do? And maybe I can start with Bob.
Sure. So I think one thing that I guess I'd like to say before even getting into how you'd handle this slow progression is that recently it's been recommended that patients undergo EGFR mutation testing, and I think that it's important to consider EGFR mutation testing in all patients, not just those that fit a particular clinical phenotype. We are in the practice at University of Colorado of testing all of our patients, and that includes squamous, which admittedly are incredibly rare, but we have found EGFR mutations in that patient population. But there's a recent JCO article documenting that approximately 40% of all mutations occur in current or former smokers. And so I think one important thing to really consider is that we should do our patients a favor and consider mutation testing in all of them. Having said that, the progression issue is a very interesting one. So what I can say is if there's a single lesion that's growing, we would typically consider biopsy of that lesion, especially if it's readily accessible, and I know this is going to come up in a minute, because it might lead to a clinical trial. The other important thing is if it's only a single lesion that's growing, I think that you can approach this with local therapy. So radiation, SBRT, whether it's in the liver or bone or lung, and then consider the Tarceva. So I think that's perhaps one of the easier situations, although I don't think we have great evidence yet to support that. I think it's a very reasonable strategy. If there's only a single lesion that's growing, we know that there can be clonal variation and that only one of the metastatic sites might have resistance, and so that is easier. If there are multiple sites that are slowly growing, I think it is a more difficult question, but I am willing to allow my patients to have slow progression. After having done this many times, it can be 6 or 8 months before there's more significant progression requiring a change in therapy.
What is your approach when they do progress enough to make a change in the systemic therapy?
So, of course, we would prefer a clinical trial, so there are multiple trials trying to evaluate combination therapies that may target specific mechanisms of resistance. So whether it's MET amplification or T790M, there are strategies that are meant to target each of those. That would be our preferred modality. But for someone like this, if a clinical trial is not available nearby, then I would consider first-line chemotherapy with platinum and another agent. Those patients have very good response rates. I mean, in IPASS, the response rates for EGFR mutation patients was twice that of EGFR wild type. So these patients do quite well with chemotherapy. And so I think for this patient, if I were going to switch, if I didn't have access to a clinical trial or we didn't fit the criteria, I would do a platinum-based chemotherapy.
And not continue the EGFR inhibitor.
Yeah, and not continue the EGFR inhibitor because of studies showing antagonism between those two agents.
If I can turn to Jyothi, Dr. Patel, I know you see plenty of these patients as well. So what is your approach for somebody with slow, modest progression after enjoying a good, prolonged response?
It absolutely depends on how the patient's tolerating the Tarceva and how many sites of progression there are. If it is solitary recurrence, I think Bob's strategy of giving local therapy makes a lot of sense. In patients who are symptomatic from their disease or have more worrisome progression in multiple organs, then we're more likely to suggest that they either, again, go on a clinical trial or that they begin chemotherapy. So one of the clinical trials we have right now, Melissa Johnson's work, is with a Novartis drug, AUY922, which is a heat shock protein 90 inhibitor. And that is targeted at the mutation that Bob mentioned, the T790 mutation. And we give the drug because it attacks sort of the chaperone protein. We think it circumvents the new mutation. And so patients stay on the erlotinib and get this weekly infusion. This is very early. It's phase 1, but we hope that it will be effective. More often, patients elect to go on systemic chemotherapy. Again, depending upon how much progression they've had and what their quality of life is. Sometimes if it's just minor progression, I may add another targeted drug, and I have certainly added Avastin to patients who are on Tarceva, and we've seen some nice results. Usually I'll add the drug Alimta, either with platinum or without. We'll plan to do sort of discrete chemotherapy, so I'll say we'll probably do 4 cycles, and at that time I'll give you a break off the systemic therapy if you've had the nice response, I would hope. Now, I am one of those that believe that if you have an EGFR-addicted tumor, then you should probably stay on Tarceva despite the progression. There's been some nice work from Greg Riley at Memorial Sloan Kettering in which he showed sort of a flare response in patients who are off for a couple of weeks that the tumor may pick up. So I generally continue Tarceva, especially if patients are tolerating it and have had really no toxicities. I'm very happy keeping the full dose. Sometimes, though, we know that people have difficulties or have upset stomach, and at that time I'll usually hold the Tarceva for around 5 days around the chemotherapy and hope that that would address any concerns about antagonism. But I tend to keep the Tarceva going.
Great.
With no data.
But I think most of us are all struggling with the lack of data for a best approach here. So, Bob, you already spoke to this. Do you routinely recommend repeat biopsy after a patient develops acquired resistance to an oral therapy? And if so, has it been very straightforward to get that covered by insurance, or is that a barrier? And then also, what can we use that information for right now? Jyothi, why don't I start with you?
Generally, we do repeat biopsies as part of clinical trial enrollment. There are patients, though, that I've biopsied because their phenotype sort of changes, so clinically they're behaving differently than they did. It's not the slow progression, but things have picked up pace. And I started doing that after Lisa Sequest presented some of her data that she had in patients. Sort of change histology, that they end up having sort of a change from a well-differentiated adenocarcinoma, for example, to a cancer with neuroendocrine or small cell features. And we've picked up a couple of these patients. If that's the case, there's a huge paradigm shift in their treatment. And my feeling is then it's very worthwhile because the drugs that you give are completely different. We have not had problems with payment or insurance coverage. I might have had some problems with the radiologist asking me why I'm asking for a biopsy again. But now that they're seeing some of our strategies, more and more people are comfortable with it. And patients are also generally willing to find out what has changed about their cancer, particularly those that have had a nice period of disease control on Tarceva.
Bob, what's your experience in Colorado?
Yeah, I would completely echo what Jyoti said in that we've also seen the small cell transitions, in which case the chemotherapy or the therapies that you would use are very different. And typically what we're seeing is all of a sudden a more explosive progression, not this kind of slow or solitary progression. I think in that case, there's now evidence that a good number of these resistance cases are small cell conversions, in which case I think it would be clinically indicated. We have not had trouble with insurance paying. I don't know how attuned they are to the issues of why we're doing the biopsy, but so far we have not had a lot of rejections. We've worked very closely with our interventional radiologists, because it's, I think, very important when we're going to rebiopsy that they biopsy the right lesion, that this is a rebiopsy. If there's multiple lesions in the liver, that you need to biopsy the one that's growing, and so we often have a very detailed discussion about making sure that they can biopsy the lesion that we're interested in, the one that's growing, to determine the mechanism. I also agree that the patients are very interested. And beyond the small cell conversion, at this point, we potentially use that information to direct them towards a clinical trial. If they have T790M, one option is to do cetuximab plus an irreversible EGFR TKI, William Pow's study. If they have MET, you might try crizotinib plus an irreversible EGFR inhibitor, pan-HER inhibitor. So I think the information is useful, although not all of it is going to lead to a standard of care as next therapy. But I think the small cell conversion is an important one to consider, and we've definitely seen that.
Dr. Suresh Ramalingam from the Winship Cancer Center, Emory University in Atlanta, Georgia.
For a patient who is progressing very slowly, but still the disease burden is much less than where we started off with, my tendency is to continue them on the Tarceva until there is either new symptoms or new areas of metastatic disease that would require us to shift course. The reason here is we don't really have very specific targeted strategies to overcome resistance, though we're making some progress in terms of early results from clinical trials. So my approach is giving the Tarceva for slow progression. And when it is time to change, I go to combination chemotherapy if the patient has not received it before. There are some groups who believe that Tarceva should be continued with the chemotherapy even if they develop progression, but I think that approach has not been firmly tested in the clinical trial. So I switched to combination chemotherapy if there was no specific clinical trial available for these patients.
Do you ever go back to re-challenge them with an EGFR inhibitor again?
I have done that after I have given one or two chemotherapy regimens. And I would say that in most instances I have not seen a major response. Perhaps the best I have seen is short-lived stabilization of the disease. When I run out of standard options, I have done that.
In this kind of setting, do you recommend a repeat biopsy after a patient develops acquired resistance to an oral EGFR inhibitor? And if so, do you tend to encounter much of a challenge in terms of payment for that insurance coverage and just the practical aspects of pursuing it?
I think obtaining a biopsy would give us the information on the mechanism of resistance. And from an academic standpoint, this is definitely of great interest to all of us. In terms of what we do with this information at this time for a patient outside of a clinical trial, the answer is we don't have any specific treatments to offer. So if an institution has a trial that would specifically address an EGFR resistant situation based on the mechanism, it would be reasonable to do a biopsy. Outside of that, at this point, I'm not recommending a repeat biopsy, but if a patient is willing from an academic standpoint, I think it makes great sense to get one.
Dr. Jonathan Goldman from Premier Oncology in Santa Monica, California.
Well, this is a case where you have lots of options. Nothing has clearly been shown to be better than another approach. Obviously, a clinical trial for a second-generation EGFR inhibitor would be a promising way to go, but at the same time, we haven't had a lot of success in that direction as of yet. I tend to use the Tarceva for longer than I would other treatments. I think that a lot of times, even with progression, the patient is still having benefit. And so I like to be convinced that there's real progression, not just increased PET activity, but real growth, for example. And at that point, in this case, I think there had not been any prior chemotherapy. So I tell the patient, in general, not only did you have the good mutational makeup to have a good response to Tarceva, you also have the good makeup to have a good response to chemotherapy. And many times I'll switch to a platinum doublet. I assume this patient has adenocarcinoma, and so Alimta, cisplatin, or carboplatin I think is very reasonable. You can even use Avastin, depending on the other criteria that the patient has. And I tend not to include or continue Tarceva at that point. I've been very convinced by several case series showing multiple retreatments with Tarceva gives you, or in other cases, Oresa, gives you repeat responses. And I've seen some cases up to 7 retreatments. Not that that's going to be every patient, but what I try to do is plan with the patient that at some point we'll likely go back to Tarceva, and it might be after 4 cycles of the platinum doublet. And the idea would be that the chemotherapy is eradicating or minimizing the Tarceva-resistant clones, and then you're going back to the Tarceva in more of a maintenance strategy at that point. But I really don't think that anyone's figured this problem out yet.
Do you currently request a rebiopsy of tissue after a patient develops acquired resistance to an EGFR tyrosine kinase inhibitor?
I think I am more aggressive than most in suggesting to a patient to get a rebiopsy. Some people are very clear they don't want to go through that again, and I don't think there's a reason to really push someone. But other patients, I think, are not too off-put by it, and in fact, I think it's oncologists who have tended not to ask the patient. I think unfortunately, at the same time, it's not always clear what to do with the information of the biopsy, but sometimes we do find, for example, that we may want to move them to a specific clinical trial at another site, or depending on what we find. And I certainly think that if the patient's interested in being part of the growing understanding of Tarceva and when it works and when it doesn't, then I think a lot of patients are willing to do that. It also depends a lot on where they have tumor. A liver biopsy can usually be done very safely. A central lung mass might be more concerning.
Dr. Julie Bramer from the Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland.
Depending on the patient, if there's minimal change, but even though if it's just one spot slowly growing and then everything else is pretty quiet, then I really won't make a change. Certainly if things start picking up and start increasing, then I'll for sure try to push the dose as high as the patient can tolerate up to the maximum dose. For us in the U.S., Tarceva, 150 milligrams a day. If that doesn't work, then I'm torn between switching completely to just chemotherapy or potentially leaving that patient on Tarceva and adding chemotherapy to it. I don't think I have convincing evidence to do either. A lot will depend on how the patient is doing. If they're well enough to undergo combination chemotherapy, then I'll probably drop the erlotinib and do the combination chemotherapy. If they're not well enough and we're looking at single-agent chemotherapy, I've usually kept them on the Tarceva and adding the single-agent chemotherapy. But there's no clear right or wrong here. Certainly trying to find a clinical trial for this particular patient would be very important, and I do try to look for that. If we don't have something, I look for that elsewhere. So that would be something very important for patients to talk with their doctors to see if there's anything locally within an hour or 2 hours that they could participate in to try to move this field forward.
Because I think the only consensus we have is that we just don't know the best thing to do. It's tough. You get a great response, but then that slips away, and we all want to get the genie back in the bottle, but haven't found the way to do that. Do you currently request a rebiopsy of tissue after a patient develops acquired resistance? And if so, how do you use that information?
So routinely, I haven't in the past, but I think as we're learning more and more, some people's tumors do change or other tumors are more evident and become more aggressive. So I think trying to rebiopsy, if it's safe for the patient, would be helpful to try to figure out what type of resistance has developed, or if the tumor, basically we've killed off all of the non-small cell lung cancer, now we're left with something else. Some of the investigators have demonstrated that some patients do develop small cells, so patients can have mixed tumors that don't develop into small cell, but actually that's what's left and becomes the primary dominant problem. So I think doing some biopsies once resistance is acquired to document what exactly that is would be important.
Dr. Heather Wakely from Stanford University Cancer Center in Palo Alto, California.
So I tend to keep people on as long as I can until, to me, there's no question of growth and no question that the growth is relatively rapid. So if someone is just sort of, the nodules have grown by a few millimeters and 2 months later there are a few more millimeters, I don't jump. But once there's true growth or a new site, then I will go. And if someone's never had a platinum doublet, I will then bring in the platinum doublet. Those still work very well, and those with EGFR mutations, and can be pretty well tolerated if someone's performance status is still good. So that's usually what I will go to next if I start with first-line EGFR TKI, unless I have a really good trial open for those who have developed secondary resistance.
And when you do,
I stop the erlotinib. I give people a break from it with the idea that if the resistance is from the T790M mutant clone, there's definitely data that that clone diminishes over time off of the EGFR TKI, and that you can bring back some of the sensitivity if you give patients a break. And I've certainly seen that in some patients.
So you've reintroduced it after an interval and seen a response again?
Mm-hmm.
Okay. You don't add anything to the Tarceva like Avastin or something like that, just switch over to what you would otherwise consider first line?
No, I don't. We're developing a study that's looking at a FGF, VEGF inhibitor. I know many people are doing similar things. But if I didn't start with the Avastin, I don't think that there's any convincing data that adding it to the erlotinib or Tarceva is really necessarily going to bring back a response. It might delay resistance development, that we did see a prolongation in disease-free survival in those studies, but nothing that I've seen that says that if you're already on it and progressing, that you add in a VEGF inhibitor, then that you get a benefit again.
And you don't have much enthusiasm for increasing dose?
So I have in patients who develop CNS disease, particularly leptomeningeal, where I know that my chemo is not as likely to benefit. I have, on some of those patients, given them high-dose pulse dosing, but I haven't had success with that yet. It's something that the Memorial people are doing more. And if it's someone with an EGFR mutation who I started on a low dose because they were a small person and I knew they had a mutation, I have sometimes gone up to the 150, but that might give you a little bit more time on the drug, but it's not going to have a drastic impact.
Do you currently request a rebiopsy of tissue after a patient develops acquired resistance to an EGFR TKI?
Only on trial. It's something that we're looking into starting to do more, but we didn't have the capacity to do the necessary or the interesting testing like looking for T790M. So it wasn't going to change what I was going to do to help the patient, except for those on trial, but we are going to start doing that more.
Dr. Karen Reckham from the City of Hope Cancer Center in Duarte, California.
So we see plenty of these patients, especially being in Southern California with our patient demographics. So we see this, and this is a very common scenario. I think there are multiple issues in this, and I think now that we're giving erlotinib or Tarceva as first-line therapy for patients with EGFR mutation, it's different, and my thought process when somebody progresses is very different than when we were giving it as second or third line, because there was really not a whole lot left when somebody was getting second or third line, whereas we do have viable therapies for patients when they have had it as first line. And what we often see, because Tarceva is a cytostatic drug, often patients slowly start to progress. And I try and take it by symptoms. I try not take it by specific RECIST, because often the tumors shrink to almost nothing. So by RECIST, 20% could be even a half a centimeter growth. So I try and take it by symptoms. And once they're in the progression stage, I tend to do scans kind of on the 2-month basis, because usually I'll spread that out a little bit longer when they're responding and not having any symptoms. So kind of give them a 2-month window for scans, watch it incredibly closely, and try and keep them on the Tarceva, because I think they're still benefiting. And I think what's happening is that they have probably 2 lines of cells, some that are becoming resistant and some that are still sensitive. Again, when patients were getting it as second line, taking that away, I think was incredibly detrimental, because again, there was not much left that was going to help their tumor. Patients who are getting it as first line still have chemotherapy as a viable treatment option, and I think chemotherapy works incredibly well without the Tarceva. And I'm not exactly sure how to pair it with the Tarceva, and it's definitely more difficult to give with the Tarceva. So again, before when we were giving it second, third line, I often did continue the Tarceva and then start something else. But now that I'm giving it in the first line, when I do decide to start something else, I tend to give chemotherapy alone. And they tend to do incredibly well with the chemotherapy chemotherapy too.
So you haven't seen too much of a problem with the rebound effect of stopping it in the face of some progression when you decide it's enough progression and they get remarkably worse?
Not in the first line.
Okay.
In the second and third line, definitely not in the first line. And that's why, so chemo, all of a sudden their tumor's growing again, and then they have this great, very positive time. So it's an incredibly different disease to treat now that we're treating it with erlotinib in the first line. Obviously, I'd like to get a biopsy to understand this tumor a little better. And as we've started to hear, if you rebiopsy over time, the tumor even changes over time. And so if they get a break with chemo, they may be able to go back to another type of EGFR inhibitor or even back to Tarceva again.
You anticipated one of my questions, which is how enthusiastically do you recommend a rebiopsy, and how do patients respond to this? Are there practical barriers such as their own concerns about safety, reimbursement, and what are you going to do with the information you have?
So I think that I'm more and more an advocate of getting additional biopsies, partially because we have clinical trials available now that are specific for specific types of tumor. And so for many people, there will be a specific answer. And even if we don't have a clinical trial, there may be one in the country. And if they have a specific mutation, for many patients, it may be worthwhile, especially for EGFR mutant patients. So I think rebiopsying, especially in an EGFR mutant where we know what happens after and we have some potential options even if they are under investigation, I think it's worthwhile. And patients, once they understand, again, you're talking about an EGFR mutant lung cancer patient, so this is a person who understands that they can greatly benefit from knowing the molecular makeup of their tumor. Most of these patients are on board. And even if there's some financial burden, it's usually in the hundreds of dollars, and their co-payments for treatments could be much more than that. So if it means that they could go on to a potential clinical trial or find something else, they're incredibly motivated.
How often do you go back to the EGFR inhibitor from first line after some interval on chemo and off of an EGFR inhibitor entirely?
So I have to say that fortunately, this is so relatively new that we've been using it in first line. I think most of the patients who started it in first line are still on the chemo part and not progressed after chemo. And so most patients haven't, but I wouldn't hesitate. I think that would be a great time is first line, second line, and then potentially what we're trying to do again is try to put them on the second generation inhibitors or other types of clinical trials. But I wouldn't hesitate to put somebody back on Tarceva.
I have had patients who are on first line, progressed, go on chemo, various things for years, and have had impressive responses the second time around. Not usually as long-lived.
Right. And most of them are quite happy to be off of Tarceva for a period of time. Mm-hmm. Once you're giving, even first-line chemo seems like a break to them once they're not on the chronic toxicities of Tarceva. So I think there is some reason to stop it. And again, as we're seeing the biopsies change, potentially the biology is changing and you want those sensitive tumor cells to grow back again, and you may be able to have better responses.
We hope that the program was helpful, and we'd again like to thank the folks from Longevity Foundation for their partnership on this program. Thank you.